we could give Jami a warm welcome.
So for those of you who don't know me, let me just tell you a little bit about myself first. I was born and raised in Northeast Oklahoma Cherokee from my father's side, a mix of Irish, French, and Dutch from my mother's side. I moved to go to school, which is what a lot of people do. So I moved off and I moved to the city. And I was like, wow, what a different experience. So try to get some city skills, which I didn't have. So I moved off, went to school, ended up out at Florida for a while studying about policy and how that was affecting our communities. And then I went home and I practiced after I finished my degree. I practiced at our local urban Indian health clinic in Tulsa. So that was really my first experience in really working within an urban Indian community. So let me give you a little overview about what we're going to talk about today. That healthcare reform law, the Affordable Care Act, as I'll talk to you about it in a minute, it's real big. It's probably about 1,000 pages, and it is a little complicated. So what I'm going to do today is I'm going to give you just a bird's eye view of healthcare reform. There's no way we're going to be able to get to everything that's in there, and there's a ton of things that are in both the healthcare reform law as well as the Indian Healthcare Improvement Act that was permanently reauthorized through this. And then I'm going to highlight some opportunities that are coming up for Indian country, as well as some challenges. And particularly as you all are the advisory council for the Circles of Care, there are things that you really need to be thinking about to help support the local community to make sure that these things are taken care of so that you all can be successful in your supporting the kids in your community. And then I'm also going to give you some resources for some ongoing information if you need it, education. And then we'll do a little question and answer. I'll do my very best to answer all your questions. If I can't answer them, I got my little book up here. I'll write them down because, again, the law is really complicated. So if I need to go back and ask our attorneys about what that law means, then I'll do that. So we'll try to take your questions. So I'm going to always want to start with definitions. I don't know how it is that we got an acronym for everything. Everybody speaks in a bunch of letters, huh? So I wanted to make sure that these things were spelled out so that everybody's on the same page about what we're talking about. So the Healthcare Reform Law is actually called the Patient Accountability and Affordable Care Act, and they shorten it to the ACA. So anytime you hear anybody talking about the ACA, that's the Healthcare Reform Law. Within the Healthcare Reform Law, we actually got the Indian Healthcare Improvement Act passed. So we got it attached to that bill, and when it passed, it went into law. So we've got that's called the IHCIA. And then we have the I and the T and the U. We talk about the I, the T, and the U all the time. The I and the T and the U represent the entire Indian healthcare system. So you've got the IHS that operates services for your direct service tribes. You've got the tribal services who've said, you know, we're self-governance. We want to take those health services for ourselves, and we want to we'll run our own clinics and hospitals. And then you've got this clinic, the Title V Urban Indian Health Programs that are contracted with the IHS to support Indian people who are living in the cities. Many of whom were relocated during that relocation program in the 1950s and 60s, and then others who moved here for school or jobs or other opportunities. So that's where American Indian Health and Family Services falls within the Indian healthcare system, is under Title V, the Title V programs. So we also have these things that you probably heard people talking about, state exchanges or health insurance exchanges. And it's a program that is in the Affordable Care Act, and we'll talk about it a little bit more later, but it's a program that's going to be operated by every state. So Michigan will have its own exchange to help people find health affordable insurance options for them. And I'll talk to you about what's in that. And there's some really good things in there for Indian people. And then there's the Center for Medicaid and Medicare Services. So this is the Center for Medicaid and Medicare Services it's at the national level, and that's how people who have low income, who need help and with their health care, they can actually get on Medicaid insurances and actually have a payer source. So in Michigan, you have your own programs through Medicaid because all of those programs are run by the state. So we'll talk about that in a minute as well. And then there's this thing called OCIO, O-C-I-I-O, And this program is what's going to be trying to put together those state exchanges. We'll talk about that in a minute as well. Okay, so let me talk to you about the very most important thing about this particular law. The healthcare reform law is what we call an authorization law. And what that means is that it gives us the authority to do things, but it doesn't give us any money. So the healthcare reform law has no money attached to it. And, you know, we've got the Indian Healthcare Improvement Act passed, which is really good, and we'll talk about that in a little bit as well. But within the Indian Healthcare Improvement Act, there's all these things now that this clinic can be doing, like immediately enrolling people in services like Medicaid services and those kinds of things, express lane entities and those kinds of things. But we have no money for it yet, so we've got to really work with Congress now to get them to fund this law so that there's money to do some of those special demonstration projects, and there's telemedicine project for youth, Indian youth, and there's all kinds of really cool programs and projects in there, but we don't have any money for it yet. So that's where we are. We got to get Congress to appropriate the funds. So one of the things that I really want to spend a little bit time talking about, how many of you all have heard about the Indian Healthcare Improvement Act? Few of you? Okay. So the Indian Healthcare Improvement Act is one of the most important things that I think happened as a part of the healthcare reform law, because the Indian Healthcare Improvement Act is now permanently reauthorized in law. And I had the opportunity to watch the last few years of the fight to get that Indian Healthcare Improvement Law passed, and I will tell you, it was a fight from tribal leaders to get that thing passed. And there was a whole group of tribal leaders around the country that were working tirelessly to try to get this thing passed for the last 10 years. So let me just give you a little bit of information about what the Indian Healthcare Improvement Act did. The first thing it did is it acknowledged the federal responsibility to provide health care for Indian people. As long as the waters run, you should have full health services. But the Indian Health Services has not been fully funded by Congress. So we're really at a place now where we've got, at least in law, an acknowledgement of that federal responsibility to provide health care for Indian people. The second piece is the authority. It expanded the objectives of what we can do as Indian healthcare system, and it also added new programs like the telehealth project for Indian youth that I was talking about. So there's a lot of really great behavioral health related programs that are a part of the law, and those are all, we have the authority now to do those things. Now we just got to get the money to do it. The third thing it did is it created parity or equality, and it created equality between the IHS federally run systems like the hospitals, IHS hospitals, and the tribally operated programs, so that now the tribes get they should be getting as much resources to operate their services as does the federal government IHS to operate those services. And then the other thing it did is it tried to create equality between tribally operated programs and the urban Indian health programs. So when we look at the entire Indian Health Service budget, the urban Indian health programs get 1%. And that budget is already underfunded by about 50% of what they need to provide adequate care. So the money that Congress gives to the Indian healthcare system is 50% less than what we need. So that's huge. And the urban Indians get 1% of that for the urban Indian health programs. So it's working to create that parity. The final thing that it did is it created opportunities for us. It gives us now the opportunities to collect money from other people to provide health services to Indian people. When you're getting services that are funded at only 50% of what you need, they're not real quality, unfortunately, and you don't get access fair, you wait on a waiting list and all those kinds of things. So we now, as Indian healthcare programs, we can now get money we can bill Medicaid if we've got somebody in our clinic that is on Medicaid, or any of your Michigan Medicaid programs that we talked about. We can bill the veterans, we can bill the VA, we can bill the Department of Justice if there's somebody that is under their care, under their watch. So we can bill any private insurance. So now we have the opportunity to bill Blue Cross Blue Shield, whatever insurance company that somebody has. So if an Indian person comes and they have some payer source, then that's bringing money into the Indian healthcare system. So that's an important opportunity. We also have the opportunity now that the Indian healthcare system can decide that they can purchase insurance for their American Indian people that they're serving. So if a community wanted to say, you know, we're just going to buy insurance for everybody that comes to our clinic, and then we're going to bill the insurance company to get reimbursed, they can do that. So those are some of the things that are available now under the Act. And then finally, there are consultation requirements where now the states, because you know typically tribal consultation occurs government to government between the tribe as a sovereign nation and the United States. And every March, I've now got to go to 3 tribal consultation meetings. It's really a neat thing to watch all the tribal leaders coming and talking to the head officials of the Department of Health and Human Services, you know, the SAMHSA and the Aihfs and the Centers for Disease Control and all those folks. But now there's a consultation requirement for the state. So what that means is the state of Michigan now has to talk to the I, the T, the U, and any tribal organization. So they have to talk to everybody if they're going to make changes that are going to affect your health care. So at this point now, it used to the state could do whatever they wanted. There was no obligation for them to talk to you, and they may develop policies that created roadblocks for you to get services. Well, now there's a requirement that can't happen anymore.